Hi everyone, this is my presentation this week on methadone. So epidemiologic factors. Nationally, according to a 2019 study, about 7% of women reported using prescription opioid pain relievers during pregnancy. The number of women with opioid-related diagnosis at time of delivery has increased by 131% from the years 2010 to 2017. Within the Arizona state where I live, the number of infants born with opioid withdrawal symptoms has increased almost fivefold during the years 2008 to 2016, going from 15 cases per 10,000 births in 2008 to 73 per 10,000 births in the year 2016. Nationally and in the state of Arizona, it can be a challenging process for women to access care programs such as medication-assisted treatment, or MAT. MAT is a program in which the patient goes into a clinic to obtain a replacement drug such as methadone to wean off the opioid that they are using under medical supervision. Only about 2 in 5 pregnant women in the state of Arizona receive this service due to a scarcity of MAT facilities available. There are many rural parts of Arizona with no MAT programs, and many providers have not yet been educated about administering MAT to pregnant women, especially within these more rural areas. This presentation will look at the medication methadone and its use during pregnancy. So maternal and fetal risks. Maternal risks for using methadone during pregnancy: possible preterm labor and delivery, physical dependence, and then headache, stomach pain, mood disturbances, and nausea can be side effects from that, and risk factors as well. Fetal risks: fetal dependence, soft spot on the head that can be bulging, decreased fetal growth, elevated systolic blood pressure, along with NAS. So according to the Substance Abuse and Mental Health Services Administration, methadone is safe for pregnant women combating opioid addiction. Obviously, methadone is a much safer route than any other opioid that the woman might be taking. MAT has been used to treat pregnant women since the 1970s. In 1998, the American Society of Addiction Medicine and American College of Obstetrics and Gynecologists established MAT programs as the best practice treatment for pregnant women with opioid use disorders. Methadone does have potential negative side effects for baby, but it's important to remember that they are nowhere near as likely or dangerous as the effects of the most commonly used opioids. The risks associated with methadone treatment are minuscule compared to the harm for baby being exposed to prescription or illicit drugs that are taken in unmanaged doses more frequently than once a day. As we can see from the maternal risks and side effects of methadone, some may mimic the common complaints of pregnancy. It is important to note mood disturbances side effects of methadone, as extra attention should be provided for the patient experiencing mood disturbances while taking methadone, as they can be at increased risk for developing depression during pregnancy along with postpartum. Here's a chart from the CDC noting the long-term effects of methadone on sex and pregnancy. So methadone can cause significant hormonal changes resulting in loss of libido, erectile dysfunction, menstrual irregularities, along with decreased serum testosterone levels. Effects of methadone on male and female reproduction. So as you can see, for men, there's quite a few listed, and then for women as well, like we just mentioned, irregular periods. Methadone is excreted through breast milk. However, it is recommended and safe to breastfeed while on methadone. There's no contraindications for that. And of course, there are pregnancy complications if doses are reduced. Most pregnant women will start with a dose, and then, during these MAT programs, we'll see how the woman reacts to the dose. Most women will need more doses as pregnancy progresses, but we just kind of have to watch it from there. And then for the fetus, like I mentioned, it does cross into the placenta, crosses through breast milk as well. There can be dependence. Once they're born, NAS can be seen, as we see the opiate abstinence syndrome on here, along with the bulging soft spot mentioned before as well. And then in early childhood can lead to some developmental delays, growth impairments, lower IQ scores along with that. So screening tools. So MAT is an evidence-based treatment protocol for people with substance use disorder, or SUD. MAT prevents onset of withdrawal, which can be harmful to both pregnant women and their babies. When compared to untreated pregnant women, women treated with methadone during their pregnancy had infants with lower risk of NAS, less severe NAS scores, shorter treatment time, along with a higher gestational age, weight, and head circumference at birth. MET has been shown to improve patient survival, increase retention in treatment, decrease illicit opioid use, among other criminal activity, increase patients' ability to gain and maintain employment, and improve birth outcomes among pregnant women with SUD. MAT is guided by providers who will see the patient daily or sometimes weekly to meet with them, administer the methadone, and follow up with this patient throughout their pregnancy. So, subjective presentation of the patient. These can be some side effects from methadone use: restlessness, nausea, vomiting, slow breathing, itchy skin, heavy sweating, constipation, sexual problems. Like I mentioned previously, many of the side effects of methadone can mimic common complaints during pregnancy, so it's important for providers to be able to provide further education regarding how to cope with these complaints. A couple on here being the constipation, nausea, vomiting. Those can be addressed, with either further over-the-counter medications or patient education as well. So, objective presentation of the patient. Evidence supporting monitoring of methadone concentrations in pregnancy is limited. Measuring serum methadone concentrations is controversial, as the relationship between methadone concentration and effect in patients with opioid dependence is not well defined. The best course of action will be for the patient to continue with the MAT program, take the prescribed dose of methadone, and follow up with the MAT provider and OB as indicated during her pregnancy. Differential diagnosis. So the provider must be vigilant with the patient and be aware of the symptoms of methadone. Complete med-rec should be compiled at each visit with the pregnant patient. Social history should also be collected at each visit. The provider must determine if the patient is using opioids for secondary gain, or if they're also using any other illegal controlled substances, prescription opioids, or street drugs during their pregnancy as well. Chronic pain disorders, mental health disorders, substance abuse disorders, and various chronic injuries and diseases should be a part of the differential diagnosis for opioid use disorder. Evaluation and treatment of the underlying medical condition responsible for opioid use are of the utmost importance. It's very important for the MAT provider, along with the OB and the patient, to follow up, be clear and concise at each visit. Hopefully the patient, will stick to the program, stick to the MAT program, follow her dosing schedule with the methadone, and be honest with what she's also doing outside of the MAT program, along with her prenatal visits with her OB. Prenatal care and monitoring. So MAT is the #1 priority for patients needing methadone treatment during their pregnancy. Recent state policy trends regarding access to MAT for pregnant women with SUD focus on implementing treatment programs, allocating funds for services, along with enhancing consumer and provider awareness. These policies reflect the understanding that a coordinated and collaborative approach is necessary to meet the complex needs of the pregnant woman and parenting women with SUD. Prenatal care and patient education, I think, is really important, so I wanted to add this slide on here. So women who are pregnant or breastfeeding can safely take methadone, as we have just established. Comprehensive methadone maintenance treatment should include prenatal care to reduce the risks of complications during pregnancy and at birth. Pregnant women who experience withdrawal may be at risk of miscarriage or premature birth, as well as withdrawal can cause the uterus to contract. So it's, of course, very important to stay on the dose as scheduled and let the MAT provider, along with OB providers, see if they let them know if they feel a change, maybe need an increase or a decrease in the methadone that they're taking. It is possible that some babies may experience withdrawal, also known as NAS. Symptoms for this can begin within minutes to hours after birth, with most symptoms appearing within 72 hours. And then research has shown that the benefits of breastfeeding outweigh the effect of the small amount of methadone that enters the breast milk. And then here are my references. Thank you.